All right. Hello, everyone, and welcome to another session here of the Virtual Global Spine Conference. It's an honor to have everybody here with us again as a couple more weeks, and it's an end of an academic year anyway, and we get right back at it in July. So it's a pleasure to have everyone here. And today we have the fortune of having one of our very own co-hosts, Dr. Goodwin. Dr. Matt Goodwin is a director of the spine oncology at the Department of Orthopedic Surgery in Washington University in St. Louis. He has presented several times here on this forum, well known to a lot of our family and friends of virtual spine. He is a fantastic complex spine and oncology orthopedic spine surgeon, and we're excited to hear him out today and see what spinal lesions he will be discussing. Dr. Goodwin, welcome, and thanks for running the show today.
Well, happy to do it. Thanks for that nice introduction, Ali. As usual, you're always too kind and too thoughtful. The talk today is going to cover a variety of things. It really grows from the fact that I gave a talk not too long ago on spinal tumors at one of these conferences, and soon after at a course in Chicago, I was talking about when we do and don't use anterior support and what things we think about. And then this came up again during Alex's talk last week, which was outstanding. And at the same time, I was also redoing our infection lecture here and giving that. And I realized that a lot of patients don't show up at your office, obviously. Well, sometimes they do actually as a tumor, but a lot of times they show up as a lesion. And there's a lot of overlap, obviously, between infection and tumor. And so rather than just making this an infection talk or a tumor talk, I figured we would just call it a lesion talk, because that's typically what we're talking about in clinic. And then we can kind of cover some of those things we think about in terms of reconstruction and how we do things. Here are my disclosures. So what's a lesion? This is something I get to talk about every day in clinic. It kind of depends on who you ask or what you look up. And as we know, language is always evolving a little bit. And so if you go to the NCI webpage, NIH webpage, it'll give you that first definition, that it's an area of abnormal or damaged tissue of some sort caused by injury or disease. If you look it up on Wikipedia, it'll talk about how the roots are from the word injury. But I think now it's used a little bit differently, actually. There's several articles, different places you can read about, what it means when it says lesion on the radiology report. And as many of you know, that typically just means abnormality or doesn't look normal. And so patients often say, it says I have a lesion, or you're saying lesion, what do you mean? I'll typically say to them, it just means you have a thing. Doesn't look like the rest, that vertebrae doesn't look like the rest of them. That could be a lot of things. And then I go on to tell them what I think of it, but kind of lead by explaining it just means you have a thing and we just don't know what it is yet. And so that thing could be a lot of things. It could be, and I usually explain this to them, it could be a cancerous tumor, could be a non-cancerous tumor, could be an infection. And then it could be in the spine, as everyone here knows, a whole host of other things. It could be sarcoid of the spine. It could be marrow changes because of anemia or a variety of other things because of medication, chemotherapy. And then I tell them it could be nothing. It could be something we biopsy and it comes back as normal, normal, normal. We never know. Or it could be something I don't understand or I just haven't heard of. And we've certainly had cases like that. And so it is important, and I tell the patients this too, I think, that you have some sort of multidisciplinary effort when dealing with lesions, right? Even if they're infections, you're typically going to involve your infectious disease colleagues. The case you're seeing at the top there is a 12-year-old girl who had collapse of L5 and has this lesion that's kind of gone everywhere, right, all around there. And this was one of the cases that I got asked about, and I said, gosh, obviously let's get a biopsy, and we did, and it was a Rosai-Dorfman disease, which I didn't know a lot about, and so we had to rely on our expert in that area. And it's a histiocytic process that can be found in kids, and we ended up kind of going through all that with the family, and again, multidisciplinary effort. And then I worked with our pediatric spine surgeon to resect it and reconstruct her spine. Sometimes the cases are much more obvious, or something that even though they're rare, you know what they are, or you've read about them in the textbook, or you've seen them. And so this is our case from Monday. 16-year-old male, has neck pain, and he feels a lump in the back of his neck. And there's a variety of things here that are going to make most of us say the same thing. So if you look, there's clearly this lesion in the posterior spine. You can see it's eaten away the posterior elements, and you can see these clear fluid levels throughout the lesion, right? And so young kid, posterior elements of the spine, fluid levels, all of this is kind of screaming aneurysmal bone cyst. Could be other things, but that would certainly rise to the top of your differential. In this case, it was an ABC, and as you can see on that axial cut, the right side goes right up against his vertebral artery. In fact, both of them got pretty close. And the right one actually butted it. So there's a variety of ways you can treat ABCs in this example. Just to quickly share this, since this is the case we just did. And the truth is, it's like a lot of spinal lesions, that there aren't large numbers like there are in other areas like breast cancers, et cetera. So in this case, here's a paper from 10 years ago now that came out of the Knowledge Forum for Tumor at AO Spine. And they looked at 71 cases. This is across 9 institutions. And patients underwent surgery, or they underwent selective arterial embolization, or they did both. And really, at the end of the day, they didn't find significant differences in local recurrence. And they had good follow-up. Usually if these recur, it's going to be an early recurrence. And then they go through in the paper the different things that are different and aren't different, and some of the nuances, right? So if you get an embolization, it might be that you're undergoing multiple procedures. 88% got more than one. If you're undergoing a surgery, well, if it's going to be an en bloc surgery, that comes with its own types of complications. And it depends on where it is, right? In this case, right up against the vertebral artery, really depends on how you're going to handle that vertebral artery and what your decision making is. And so, like you'll see in many of these papers, the decision of how you treat this it becomes really unique. You can lean into the data, rely on it some, but what you actually do is going to be different for every case, and it's going to come down to knowing the anatomy, talking to the family, figuring out what the risks are for each thing. If you look at whether there's other options, so here's 17 patients at one hospital, all underwent a gross total piecemeal type resection. Of these, 4 had recurrence that were then successfully reoperated on without further recurrence. And so lots of ways to do this. Again, if you look at some of the most recent reviews of all of these studies, these are just a few of them. This is a paper last year, that again talks about how if you're going to do the embolization, then, A, it needs to be something you can embolize safely. And B, it might take multiple treatments over time, right? So that might not be very appealing to some folks. And so what did we do? Well, it's a 16-year-old, got an ABC of budding the vert. We talked about all these things with him and his parents, and they were very normal and nice and smart people, so it made it a lot easier. And at the end of the day, I said, we should try to embolize the lesion itself before for safety reasons. There is a role for other agents, probably not in this case because it had eaten away a lot of the posterior elements and was relatively unstable here. And at the end of the day, we sent them for embolization beforehand. Now, when they embolize these, as you know, they look for feeders. And sometimes they either can't find a big feeder, so sometimes they find lots of little things causing blush and no big thing to block. Sometimes they find, if it's in the cervical spine, communication, as you know, with other places, that they don't feel like it's safe to embolize. And so you can, if that's the case, do things like this, where you do a direct embolization into the tumor itself. And so that's what happened with our patient. They couldn't find any large feeder. What they did find is some backflow back to the verts with little communicators. And so they ultimately decided to do a direct embolization. And then we took them to the operating room for non-block resection. How did we handle the vert? Well, we told the family that we would like to not risk his vert in this case. all things considered for these tumors. And we basically said we'd be willing to kind of work right down to it to do an en bloc. But if it came down to having a little bit left on the vert or damaging the vert, we'd prefer to not damage the vert. And it was so, the truth is it was so destroyed by the time we got it all isolated and down to that area, it kind of just fell off. There wasn't really much left on it. So it actually went quite well. And we don't have, of course, no follow-up because we just did this Monday. Sometimes the lesions are much less obvious than that. So here's a patient I saw a few weeks ago who 71-year-old. She was seen in clinic for these marrow changes at T3 and 4, which you can see on that middle panel on that T1. And so I talked to her and said this could be a variety of things, right? And so she needs a full workup. And so sent her away to get the full workup and said, well, after all the imaging is done and the labs are done, we'll talk about her at our tumor board and decide on whether this needs to be biopsied or not based on the workup. And as you know, there's a difference typically in how infection and tumor looks, right? And so typically in panel A here is what infection might look like, certainly discitis, where it affects the disc space first and then erodes into the bone. Whereas typically tumor looks more like B, where it starts in the bone and is relatively disc sparing, right? And so in this case, this patient comes in and it's actually pretty hard to tell, right? I can tell there's marrow changes. I don't know that I can tell much else from her imaging, and I told her that. So the workup was going to be very helpful. Unfortunately, she came back because in the meantime, while getting worked up, it was noted that she had collapse at that level. And you can see now that she has imaging that looks much more like an infection at this point. And sure enough, all her workup for tumor was negative, and a biopsy led to this being us discovering that she had MSSA here. So she was taken to the OR. We corrected her alignment some. We debrided there, put a cage in, and she did quite well after that. Went on IV antibiotics after that as well. So spinal infections typically we're talking about discitis or osteomyelitis, but there's other infections too, right? Like epidural abscesses and some of the atypical things we'll talk about, including post-op infections. And it's become a topic that, for whatever reason, we've talked a lot more about, it seems like, in the last year or two. And so we've done a variety of these Ask the Expert sessions with our colleague, Dr. Wendy Gibbs, asking about some of the imaging characteristics. We've had on this channel, we've had multiple infectious talks that I think have been outstanding because there's just such a variety of data on infections and how they're treated. And it's a big deal because as many of you have seen, diagnoses are often missed. Complications can be devastating. And there seems to be that we think these are a little different than other ortho infections. And there's obviously debate about that. But you'll see as we go through the talk here how we end up using metal more, for example, in spine infections than we would other places. So whenever I'm giving the infection talk to our fellows here, I talk about how at baseline, it helps to think of discitis as a non-surgical disease unless it becomes surgical, and think of epidural abscesses as surgical diseases unless for some reason they're not surgical. And hopefully with a few cases, that'll make a little bit of sense here. So here's a gentleman, 62, comes in back to Remic, sick. He's got neck pain. He's got bilateral arm pain. He's relatively intact, but he has brisk reflexes. And if you look at his imaging, he has a clear epidural collection here, ventral to the cord at 6-7, and he's got cord signal change. Okay, so you might want to go in the front and do something. Well, to complicate it, this guy's had laryngeal cancer. He's had all sorts of work done to the front of his neck to where he's got some non-healing areas, some non-healing wounds. And when you talk to ENT, they say you absolutely can't touch the front of this guy's neck. It'll probably kill him. That tissue's already a disaster. It really can't be touched. And so the question is, well, what do you do now? And maybe, I don't think I can see the chat, but maybe in the chat, if anyone wants to put 1, 2, 3, or 4 here, the question is, are you gonna Given that he's relatively intact, but with brisk reflexes and you can't go in the front, you're gonna not touch this. Do you do something from the back, decompress and fuse? Or do you say, look, we have to go in the front, is his cord's at risk here? And in this case, maybe I can see the chat. Maybe I can see the chat. There we go. I can see it. All right, I got the chat. Yes. So I see some others that would go post. So in this case, we went posterior, decompressed and fused. And in this case, we did a wide decompression, used the ultrasound to assess where this collection or phlegmon was. And then we actually got an instrument into it. And he had an uneventful recovery and did quite well after this. And in follow-up scans, you can see that was gone, and his cord recovered well as well. So typically, you want to go through a kind of a thought process when somebody has a lesion that could be an infection. And when you get down the path of it being an infection, you want to think about things like, well, of course, is it an infection, like we said? And then you want to think, what's the source? And that's, for whatever reason, I feel like sometimes some of the residents are working this up, forget about some of these things. So do you have a source? Is it operative? And if it is this a thing that we need to act on quickly or not? And what operation are we going to do if that's the case? And so here's another case. We'll kind of just sprinkle these in throughout, of a gentleman who's a previous spinal cord injury at T11, but had an ACDF 4 days ago, and get called down to the ED, and they say, hey, this guy's septic and febrile, and you got to wash out his ACDF. And so, it'd be a little unusual to have an infected ACDF, as everybody here knows. It's also post-op day 4. You go and see him. His neck seems fine. You examine him. There's a film from post-op where he had swelling. None of that swelling's there now. And he's a previous spinal cord injury, and you roll him, and he's got a huge wound with stool in it. And so, clearly you have a different reason for why this guy's probably infection. So you always want to be thinking about what the source is in these cases. And in that case, right, the neck would be a little bit of a cervical spine is not the most common spot that you see this. Most of these are in the lumbar spine, not that they can't be up there. Obviously, before antibiotics, discitis was a deadly disease. Things are much better, like most things, now that we have such good antibiotics. And I think this slide is one of the major issues with diagnosis, right? Is that the findings and the things you're looking at are so broad and all over the map, right? So, maybe they have a fever, maybe half the people have a fever. They might have some back pain or tenderness. Lots of people have back pain or tenderness. And even your cultures, right? You get a blood culture looking for a source. That's not always your answer. Even the biopsy isn't always the answer. So that makes things pretty difficult, I'd say, in the diagnosis department. And sometimes folks would say, we're missing some of these that we think are degenerative, and they're probably infectious. If you look down at the treatment options there, so look for a source, determine urgency if it's surgical, biopsy if no source, blood cultures are negative. And again, surgery is not the first line, but you could end up there in some cases. Kids are treated a little bit differently. Typically, they don't get a biopsy, but I don't regularly treat kids with infection. I do with tumor, and so I can't say that I'm on the front lines of infection for kids, but that used to be the case. Here's a whole list of a slide that probably isn't very helpful to any of us right now, because if somebody has an infection, you should be reaching out to ID to help with the regimen based on where you are and what the resistance is in your area. But it's typically antibiotics, it's typically IV, depending on bioavailability. And how do you end up in surgery? So you see here at the bottom your surgical indications. And so it can be somebody that's failed antibiotics, which can mean a couple different things. It can be that they have instability or a deformity that needs stabilization. Could be they have cord compression or neurologic compromise. Could be they've developed an epidural abscess, or a number of other things that might push you towards making it surgical. open biopsy is not something we typically do much of anymore. And source control, I know, is something that we've certainly debated before, and we could probably debate again moving forward. There's some data that's not always a great reason. So what are you going to do surgically? Typically, you're going to debride, decompress if you need to decompress, stabilize if you need to stabilize. How are you going to evaluate the follow-up here? Well, typically it's following labs and clinical exams. So you might be looking at their CRP. You want to see that their clinical symptoms are doing fine. You want to know that you're treating the right organism with the right thing. And I like for them to have infectious disease follow-up. And I personally, I like to always check and make sure they've seen ID and there's been some conversation. I've had plenty of people come through that, patients do what they want sometimes, that decided they'd stop antibiotics or, or whatever. And so I always try to make sure that they have a plan that they're sticking to. We don't have imaging on there. Certainly you would get films if you had hardware in there. But you really don't need to do an MRI if it's discitis you're treating. In fact, you probably don't want to for a lot of reasons unless they have a new symptom. And so the MRI typically takes months to change. And so if you got an MRI 2 months later, maybe a month later, it's going to probably look the same, might even look worse. And it might even be a patient that's getting better, right? And so many of you have probably run into this where some well-meaning medicine doctor orders an MRI a month out. They're being treated appropriately, CRP is coming down, they're clinically doing great. And then there's a bunch of noise generated because they think the imaging doesn't look good. But that's typically not the way you're going to follow discitis. Now, if you think they have an epidural abscess because they have new symptoms, if they have new deficits, if you didn't know the organism, there's different reasons that you might end up getting advanced imaging, but that to follow the course of disease is typically not the way to do it. All right, what about metal? What about hardware? Well, there are a lot of opinions about this, and there's a lot of different studies, and a lot of them are not very good. And whether you say hardware or instrumentation, I think technically hardware is what is left behind, right? What's left behind is not a measuring device like instrumentation typically is, but language evolves. People use both of these. Metal is what we're talking about typically in this case. And so I'll skip to the end, and then we'll go through a few studies and cases. But when you look at infections that get metal put in for whatever reason, typically seems to be fine, right? And is that because when you don't put it in, you're not stabilizing the spine and people do worse? Possibly. Is it because it's easier to clear the infection when things are stable? Possibly. At the end of the day, it doesn't seem to be a huge difference in a lot of these cases and a lot of these studies. That being said, I think people that take a hard look at infection still think it's probably better to get the metal out in an infection if you can, right? So if somebody's fused, they have an infection, you can remove the metal. That's probably not a bad idea just because of biofilms and biology. Nonetheless, there's lots of these studies out there. All of them, not all of them, a lot of them are not very big numbers where they look at, say, decompression alone, decompression fusion, there's no difference. They look at things like whether you use a cage, whether you use allograft, and don't see big differences. Whether you use autograft versus allograft is another one that's been looked at in some of these groups. They don't see a difference. And so again, the summary statement is that it doesn't seem like it really matters a whole lot what you use. Certainly not as much as it does in other parts of the body. It does seem to matter whether you do the right surgery. For a long time, we've said, probably matters that you debride the infection. I still say that, but certainly there's some papers coming out that say maybe that doesn't matter either, right? Maybe the actual source in cases of discitis, for example, doesn't matter. It's going to be treated with antibiotics. And so some of these papers have looked at fixation alone without debridement and have found that there's really no difference. And so you could certainly make the case for this in select cases, right? And they go through some of these in the literature. Been revisited a few times and with similar findings. And I think most people interpret this today as there are certain patients where you might not be able to do much because they're so sick, or they're not going to tolerate it. And in those cases, it still may help to stabilize them. Coming back to this idea of anterior support, well, I think for tumor and for infection, it really depends on the case, right? It's really case by case. And so this is a slide I put together in a tumor talk, going through the things I think about in general when I'm thinking about the construct and how I'm treating primary versus metastatic tumors. And I think infection actually pulls from both of these lists. So as an example, I think in infection, you typically do need a fusion because you're anticipating they live through this infection and that you'll need them to fuse. I also think in infection, it's helpful if you look at where the disease is. If you look at the end plates around where you might put a cage, if you look at the end plates, or if you look at the vertebral bodies where you're going to put screws, like you would in a metastatic case. And so what are some examples of this? Well, this is a patient who came in with, I think I showed this case at some point, with a dislocated spine here. Legs were out, terrible metastatic disease throughout her spine, lesions at every level. And in this case, we were worried enough that screws would hold in her spine that was riddled with disease, much less a cage. And so, no cage, get the pressure off the roots, get her realigned, and get her to a point where she can, at least stand, transfer, get on with treatment. In this case, she actually did really well. But certainly, there wasn't really much thought about putting any sort of cage or anything that we thought would just subside into the tumor here. Here's a case that's a little different, a patient with metastatic disease. And you see in this case that she's got disease in the end plates around where the lesions collapsed. If you look there's not, some kyphosis, but it's not terribly significant. There's also pretty good bony support here where it's kind of collapsed down. There's a lot of bone there. I'm not showing you all the cuts, obviously, and no bony retropulsion, right? It was soft tissue in the canal. So this is a case where you're typically going to do fine without anterior reconstruction, right? And that's the case of what we did here. I would contrast that with a case like this. So there's a case of someone with metastatic disease, but they had radiation at this single level before, and now they have post-radiation collapse. The vertebral bodies around here were unaffected, great end plates, has some kyphosis here. When you look back and forth on the CT, the bone in the front here is all crumbled, no good bony support, and there's retropulsion into the canal here. And so these are all things that would make me say, reasonable to get the bone out of there, correct the alignment, and put a cage in this case. While you're doing that, you're also trying to figure out what levels am I going to address, how big or small I'm going to go. As we get new techniques, this obviously evolves some. Here's a case from 2 weeks ago, 80-year-old male. He's got metastatic disease, spine, liver, lungs, decent prognosis overall, but he's been in rough shape. He's got paresthesias. He's got terrible back pain. He's been pretty limited for the last several weeks in terms of moving around. He's had an open heart surgery in the past, lots of other medical conditions. And so again, you look at this and you go, okay, well, his alignment's okay-ish. It's not perfect, but it's okay. He doesn't have any bony retropulsion here. He does have disease in his end plates on either side. And so you might be thinking, well, maybe we can just do all posterior, get things decompressed and go, T910 to L3 or so. But if you look, he's got this really severe degenerative stenosis at L3, 4. And so you might say, well, maybe we include that, especially since he's been so limited. Maybe that's part of the issue. And so maybe we go down to L4. And then you look at a CT and you say, well, he's got pars defects at L5. And so, well, that's not a great idea. So maybe we go T9 dose pelvis. So now all of a sudden you've talked yourself into this big surgery in a guy who's clearly not going to, or probably not going to tolerate a very big surgery. So probably not a great idea. So in this case, we did not, what were our choices? Yes, in this case, we went down to L3, right? And then we kind of used a variety of techniques to help ourselves here. We used a allograft strut on one side, which you can actually see here for added support. And then we've gone down and put a hook on the other side. just the lamina hook below our last level. So it gives us another point of fixation further down from the pedicle without, without sacrificing movement of that disc, right? So we still stay away from that degen stenosis. And, excuse me. And he ultimately was back up and doing well. We're obviously thinking about fusion in these cases, and whether we think something's going to fuse or not, or how much effort we should put into something fusing, varies, right? And so here's a patient who years ago got the surgery in the left for metastatic renal cell that's a big piece of cement in there, did well, had recurrence of disease at the upper level. I decompressed her and extended her up some. She did well for another couple of years, and then finally broke her rods. And so this is a case of a patient who's not going to fuse here. She's been radiated multiple times, had multiple surgeries, and so and she's years down the road now for metastatic disease, and she has it various places in her body. She's done well, but she's the patient who you say, typically you'd say, well, that you might break your rods in another 5 years. And if you do, we'll high five that you're here 5 years from now and do it again. But in this case, we do a relatively short surgery she recovers well from and replace her rods. I'd say very different from this guy, who 49-year-old shows up in clinic. I think he was over a year out from his en-bloc surgery at an outside hospital. And he comes with the story of being a year plus out from an en-bloc resection of an NPNST. And you read the op note, and it's clearly not an en-bloc resection. There was a soft tissue team that removed all of this stuff and then turned it over to the spine team, who then did a piecemeal resection, corpectomy, and cage. And interestingly enough, the path came back as a rare variant of metastatic melanoma that was incredibly responsive to immunotherapy, to the point where he was clear of disease after going on it. So I spent a while talking to his oncologist trying to understand it, but very, very optimistic about his overall prognosis of being clear of disease, actually. And so he ended up seeing me because he was seeing an oncologist here, and he had questions about activity levels and things like that. And I told him, I said, well, you're clearly not fused through the cage here. And when you go through his scans, he didn't look like there was much decortication or graft or anything in here. And I said, well, you're going to break your rods at some point, most likely. It's just a matter of when and what that means, et cetera. And so he tried to limit what he does. We all kind of didn't think it was enough to kind of jump in and do anything right then, until he proved us right. And he came back with 2 of his rods broken, I think about a year later, something like that. In this case, every indication is that this guy's going to be around. His oncologist says, yeah, he's clear of disease, responded incredibly. It's this new thing. And so we care very much about this guy fusing. And so we took him back and did a vascular fibular autograft, which you can see here. We've tied it in and packed it out with graft and burred up the bone that it's on and burred up the graft itself. And certainly we want this guy to fuse long term. What about if they have poor bone? That's another thing we run into, right? And so here's a patient with poor bone. You worry about subsidence. You worry about putting something in there that's going to migrate. And so it's a patient who's had an area of collapse from an infection. Dex is negative 2.9, and they are presenting like this. And so it's a case where, again, we thought not a great idea to stick a cage into this bone that was pretty compromised at this point. So we did posterior fixation only, used some cement, as you can see here, to keep the screws from pulling out. And this patient was back up ambulating and did quite well. It probably contrast that with this case, where this gentleman also had an infection, also had collapse, but had pretty good bone. You can actually see on the CT his bone was pretty good. And so similar case, except had a lot of kyphosis at where you can see there just above the thoracolumbar junction, and wanted to correct that. And so we did reline them and put a cage in there, plus use some struts in the back. I think if I had done this again today, I probably wouldn't use the cement that I used here. I don't know that he necessarily needed that because his bone wasn't terrible. So things to think about, things to consider with infection and tumor instrumentation. Obviously careful planning where your construct ends. Certainly consider use of cement, like we just went through. Um, I like to use bicortical screws a lot, like you see down here, just to get a good purchase or get the most purchase I can. I don't think it's a bad idea at all. If you need a cage, think about, can you put it over screws or cement for support? And then whether it's infection or tumor, right? I'm a strong believer in multidisciplinary approaches to these folks.
Hey, Matt, quick question. This is Ali. Sorry to interrupt. Can you comment on your experience with cement in osteomyelitis cases? I've kind of heard both sides of the story. Some folks suggest that cementing is, maybe not a good idea in case the actual, bug gets into the cement and it's impossible to eradicate. But as you mentioned, sometimes there's just poor bone quality and you need cement for the fixation. What's been your experience with cementing in osteo cases?
Yeah, that's a great question. I have also heard both quite a bit, and I also don't know the answer. So my experience, I guess I'd say, is I'd put it in there with the allograft auto, with all the things that we kind of don't know. It seems like it does fine. I've never had a problem doing it. I've obviously used it in lots of infectious cases. I do use cement a lot less now than when I started. Um, for whatever reason, I think maybe I'm a little less nervous about some of the bone I work with after getting lots more reps in. You kind of get a better feel for, well, if I put a bicortical screw, it's actually gonna be pretty good. Like I said, that last case, I probably wouldn't have used cement had I done it now. But I can't say I've ever had it be an issue. I have heard the argument. I don't know great data to support the argument of not using it. So I guess for me, I still fall back on, if you think they need it for the construct, probably not a bad idea to do it.
Thank you.
So here's a case. This is a tumor case. This is my surgery. And you can see she collapsed at the top of what I did. And if you go back and look, it's always humbling to look at what you've done, right? If you go back and look, I ended a construct where she had a lesion. And this is a month or two out maybe where the lesion started to grow. And but you can see the lesion on the original MR as well. And so probably not a great idea, right? This is a great example of a lesion at the top of a construct growing and just totally collapsed the bone there. And she collapsed on top of it. And so in this case, terrible bone, lesions everywhere, not a lot of other options besides using a cage in this case, because she was so kyphotic here and so symptomatic. And so I got it realigned, trying to put the cage between two screws. So if it did subside, it would be hitting screws, tried to use long, just bicortical screws here as well. That's a good question, actually. There's a question in the chat about the vascular graft. And so we do have a flap team. The question is, did you have plastic surgery? Did the anastomosis? What vessel did they use? And what did you tie the graft with? What did you tie I believe they'd be down to the bone. We call it the flap team. And the reason is because our flap team is really led by our hand surgeons here, because there are microvascular surgeons. And so they did all of this work. They do actually work with the plastic surgeon just on the bigger team, similar to how we work with neurosurgery on a lot of big cases, just because it makes us all better, more flexible, really, if who's in town and stuff. But yeah, our flap team is actually led by our hand surgeons, and because of their experience in microsurgery. And so they use vessels. They actually just harvested vessels from the chest wall, from the rib for this. And so while I was working, and while one of them was harvesting the fibula, the other was working on harvesting the vessel. Tying the fibula down, I use number 5 fiber wire. It's fantastic. I recommend it. It's unbreakable. You get a little Houston passer, and what I'll do is I'll actually shave the graft a little until I get it to where I can wedge it where I want it, and it's got good bony apposition. I do this with the allografts too. And in my head, I'm putting that graft down there on bone. You can see here, in my head, I'm putting it down on here. I'm putting that graft on there, and I'm shaping, and fitting to where in my head, I'm saying, could this stay even without tying it in? If that makes sense. I'm trying to make it really fit nice, bone on bone. I'm decorticating both surfaces, and then as I have it sat where I want it, I'll actually take the drill to make those holes through and through that and through the spinous process, and then I'll do that fiber wire. I'll put the Houston basket, loop it around the wires on either side. I'm sorry, the rods on either side, and then I'll tie it over it, and I'll even do a little notch in the spinous process on the top just so it stays in place. And if you do one on each end, they usually stay in there super, super tight. It's a good question. Similar case, metastatic disease in this case, 77-year-old. Another one of those cases that's going to make you kind of think and figure out how you're going to approach it. Admitted with intractable pain, myelopathy. Now they can't stand. Now they're getting some deficits. You can see even over, what is this, a month, almost 2 months and a half, their tumor's growing pretty quickly here at this level. And so when you look at their CT, I can't remember what the SINS is here, but it's pretty high, right? It's eating away a lot of the bone. It's eating away both of the pedicles at that level. They got kyphosis here, lytic lesion, and they have cord compression, right? And so all these things are leading you to operate. Biopsy is done, and it's myeloma. They get them on steroids, and they're stable. So the question is, they're going to have a surgery, but what's the surgery here? And it's not an easy thing, I don't think, because you look at this and you go, well, you're not going to decompress it alone, right? That's, I think, clear. But where are you going to instrument when you do this? How are you going to stabilize this? You go T3 to where? Well, you're going to stop above this big lytic lesion at T10. Well, that could be a problem, right? That could be a bad deal. Are you going to stop below there? Well, if you go below there, you can see he's got this degen lumbar curve, so you might not love that either. And then going up, you probably don't want to go too high, right? Because you got these lesions up there, and you got a cervical spine that's not awesome either. And so you real quickly kind of go, I'm not sure what I'm going to do here. This is a problem. On top of that, as a gentleman that, like a lot of these patients, isn't very healthy, right? All sorts of past medical history. And so this is a great case to, like many of these, talk about it with your colleagues and say, who's got some ideas? In this case, we talked to Interventional, and we basically said, hey, can you put some cement in this 10, which they did, fill it up, and that probably will allow us to go a little shorter in this case and get this guy back up and moving. And sure enough, that's what we did. Got some cement at 10, kept it short. I got him corrected, and he actually got up and did really well after that. Cements come up a couple times. It can be very useful. Just be careful. You don't need a lot. There's papers on this. I'm not showing them here, but you don't need a lot to hold a screw in bad bone. It's about 0.5 cc per screw. And I've done them without fluoro. I've done them where we do a lot more, but I do them with fluoro now. If I do them, I think it's safer. I think it makes more sense. And then I always talk to anesthesia literally as I'm putting the cement through the screws, and they say, we're putting cement in. I want to know if there's any change at all in the vitals. I want to know if the saturation changes even a little bit, because I'm not so worried about the cement going to the lungs, which is a possibility. But I always tell them that when I push that cement in, it is going to push fat out of that vertebral body into vessels, and that's going to go to their lungs. And so you don't want to give them this huge embolic load when you do this, right? And so you want to be thoughtful when you're doing this. And there's a case we did a lot of cement, right? I've shown this case before. This lady's like 5 years out now. I'm back working. It was a myeloma case where her back basically collapsed, and she was unable to get up. And we ended up cementing a lot of screws and putting a cage between cemented screws, where she collapsed, and she did great. She's actually like a normal person now, which is kind of amazing. So infections, if it's unstable, stability is likely going to help. If they can tolerate anterior support, great. If they can't, it still might be okay. There still might be a way to help them. And of course, cement and hooks are things that can help, as we showed. There's other stuff that we should mention here at the end. The atypicals, right? So the TBs, the fungus, brucellosis, these are all things that can look less like infection, more like tumor. They can be disc sparing. They can track under the anterior ligament. As a case of a guy, excuse me, who had 20-pound weight loss, fatigue and back pain. Here's his imaging. And when you talk to him, he immediately said, hey, and you say, have you been anywhere? He says, yeah, I worked in a warehouse in Arizona where I was told fungus could infect my lungs. It was almost like a board question in the hospital. It's kind of amazing. And so you pull out your map and go, oh my gosh, this could be a fungal thing. And sure enough, this guy had spinal coccygeomycosis and got the surgery you see here, which was challenging because this guy was 7 feet tall. And so we had to use our biggest cage, and then we had to cut some different allograft femurs and be creative to get it to work, but ultimately did well. In our area of the country, we also see things like blastomycosis and some histo. This is probably specific to where you are and what you see, but it's worth knowing because a lot of times, like a lot of things in spine, other people may not recognize it or may not know what to do. We'll end with a quick word on epidural abscesses. We're not going to get too into the nitty-gritty here, but it's worth mentioning because, as mentioned, it's a surgical disease until it's not, and it can cause problems, right? And so we'll skip some of this stuff, right? But the reality is somebody who has an epidural abscess, I would recommend you get an MRI of the entire spine because you'll oftentimes see skip lesions. And what you don't want to do is have them get paralyzed by an abscess that you didn't recognize. So very much a good idea to get the whole spine imaged if you can. Theoretically that you're going to see this rim enhancement on the right here when there's an abscess, and maybe you won't if there's a phlegmon. Many of you know, like I know, it's not always that clear in the spine, probably because the space is so small there. So what do you do? Well, there's been studies that looked at whether you could treat folks non-operatively, and sometimes you can, is the reality. And so people have tried to figure out who you can treat non-operatively, and it's tough to figure out. And so one of the early papers looking at that was this one, where they looked at folks getting managed surgically, and then another group that got antibiotics first until they failed, and then they got converted to surgery. And a couple things came out of this. One is if you failed antibiotics, your motor score actually got worse, right? So you had deficits as a whole moving on, and so it's worse, right? And then they tried to say, well, if that's the case, if we're trying to avoid people failing non-operative treatment, what are the things that cause them to fail it? And there have been a couple papers since then that did the same thing. And so in this paper, they looked at the 4 things that they came up with out of their regression analysis is here. And what they found is that if you have one of these factors on the left, there's a 35% chance you'll fail non-operative treatment. If you have 2, 40%, right? If you have 3 or 4, it's pretty much guaranteed you're going to fail non-operative treatment, or it's getting closer, right? And like I said, this has been repeated. There's been, I don't know, there's probably 10 or 12 things now in different studies and where they've parsed out what contributes and what doesn't. So again, most need an OR. The question is when, and that's been something people have looked at. And I'll tell you that if it's cord level, because so many of these patients treated non-operatively fail, it's pretty easy to make a case for emergent decompression in a patient with epidural abscess. And there's different things you can use here, algorithms to say, are we going to the operating room or not? How quickly? If you look at early versus late surgery, again, there's several studies now. There's different timing people have used. In this study, they used 48 hours, right? And showed that motor scores were different if it was before 48 versus after 48. This has been done with 24. It's been done, I think, out to 72. And the big story is that, earlier is probably better, right? And how you define early is going to vary a little bit based on the study. So if it's a cord level abscess, you probably need a good reason not to go to the operating room fairly soon. Now, if it's not cord level, if they have a lumbar abscess, these might be folks that do better treated non-operatively, or it's just that the risk is not so severe in that case. finally, we'll wrap up mentioning that, sometimes you're seeing things that aren't infection, and maybe thinking they are infection. So, and there's been some data on modic changes on the bone and what the differences are between looking at degeneration and looking at infection. Um, there's been some papers suggesting even that some things we think are degeneration are low-level infections. There were some papers a while ago on this claw sign. I've been told by my radiology colleagues this is actually not very reliable, so we're not going to spend time on this. But it's more studies trying to parse out is it degeneration versus infection. I think it's worth knowing that at times it can be hard to tell the difference. Finally, post-operatively, we'll end with this case. So, 60-year-old patient who gets life flighted in 10 days out. This really happened because of what was reported to be a psoas abscess and inflammatory markers that were up. And so when you look through the imaging, the abscess was actually some fluid around the psoas, consistent with the surgery they had. And clinically, they were fine. They did have a slight radic. And the CRP was up a little bit, but it was consistent with the fact that they just had a surgery. And so if you look at some of these studies, you'll see that both CRP and ESR typically will bump after surgery. CRP, for example, is going to go up a little bit and typically come back down within 2 weeks or so. And so if you see a little bump after that, that's very well could be what you're seeing. So this was a case where the guy unfortunately got life flighted for a post-op radic, which is unfortunate. There are risk factors with getting an infection afterwards. Long surgery, revision surgery. A lot of these you folks know. There's things we do that are pretty well grounded in literature in terms of getting perioperative antibiotics, irrigating. We could talk about vancomycin, the various formats. But to conclude, I'd say, treating spinal lesions, whether it's infection or tumor, can be challenging. And I do think that whether it's tumor or infection, I'm a big believer that the multidisciplinary approach is the way to go and can be very helpful in a lot of these cases. So with that, I think we have a minute or two, and I thank you for your time.
Thank you, Matt. That was excellent. These are really two important topics that are just, like you said, they're just so related, and the management can be tricky. I like what you mentioned about, if you can just comment on that once again. So an epidural abscess, say in the cervical or thoracic spine, so cord level, without deficits, but somebody comes in with pain, or even if it's incidentally found as workup for sepsis or whatnot, your recommendation is surgery sooner than later for an abscess at the cord level, even without deficits. Can you just elaborate on that or emphasize that again?
Yeah, I think it's kind of funny because for several years when I gave this talk, I remember giving it, and a resident or fellow would be like, "Well, we have, this patient over here that has a core level abscess, and we're treating it non-operatively." And so I think I guess what I'd say is it's easy to make the case that it should be treated operatively sooner rather than later, unless you have good reasons for it not to be. And I think those reasons are varied. I know some of the ones that have come up that do come up, right? I mean, sometimes the patient has so many other comorbidities, they're not going to tolerate being turned prone. They're not going to, you're like, I don't think they're going to tolerate surgery. There are other times when, to your point, asymptomatic, maybe it's a really small epidural abscess in a very reliable person, and they say it's been a week, and you go, and then maybe you have evidence now that you've seen it there for a week, right? Because they were in an outside hospital, and we've had people like that we've also treated non-operatively. Well, because you kind of go, I'm not sure, and you kind of can tell them like kind of the problem is if it goes south, it could be a real problem, right? But then there's we've certainly had cases like that where you go, but it's been a week, it's been 2 weeks or whatever it's been, it looks the same. Gosh, I might, for my spine, I might say, why don't we just, I'll tell you if anything's changed, you know what I mean? So I that being said, in those cases, I don't think anyone's going to fault you for a core level epidural abscess going to the operating room. Do you know what I mean?
Yeah, no, not only is no one going to fault you, but you'll become very good friends with ID service in your hospital very quickly. Source, where I mean, source control, they're big on that. They're big on, being a little bit aggressive with, like you said, listen, somebody has an abscess or an infection in the spine, you'll never be faulted for taking a patient to surgery, for debridement or washout, just to decrease that microbial load, if you will, or milieu. Anybody else has any questions? You can feel free to write any comments or questions in the chat, but that was absolutely excellent. Thank you so much, Matt.
Well, thank you. We've also I think we've been burned twice here over the years with somebody being treated non-operatively and goes home weeks later and hasn't progressed. And it's just such a hard thing. It's a hard thing. There's so many factors that go into it, and you'd hate for that to happen. So I don't think I've been burned on it, but I know I've been around when people have been burned on it. It's not fun, obviously.
Yep. All right, wonderful. Well, thank you again, Dr. Goodwin. Thank you to our audience, our co-host. Another phenomenal session. This recording will be placed on the YouTube channel, so folks can either send it to other colleagues or review it at a later date. But a really nice talk. Thank you, Dr. Goodwin. We'll see everybody again next week, and keep an eye out for those emails, which will have the topic and the flyer for next week's session. So thanks, everyone. Have a great night.
Perfect. Thanks, Ali. Thanks, everyone.